Okay, Deepa, we're ready to go.
Okay. Hello, everybody. Welcome to the spring quarter MPH thesis presentations. It's really nice to see everyone's pictures and live cameras on and see us all here in one place as we kick this off. So just as a reminder, I'm Deepa Rao. I'm the director of the MPH program in global health. We're super excited to launch the spring quarter presentations. I know for some of us, it came quickly the end of the quarter, and for others, it's taken a little longer, but we are so excited to have you here, all of you, the supporters, the peers of the students who are presenting, family, staff, and all the faculty to help enable this work to happen. We're thrilled to be here for this moment in our students' careers and basically to kind of witness this rite of passage of sorts. For those of you who are presenting today, we realize that it's been a unique and difficult year, but I wanted to say, hey, we're here, you overcame it, we're at the end, and look how far you've come with your MPH degree, like so closely within your grasp. So definitely a moment to celebrate. Special thanks to Noura for helping us pull this all together, under not ideal circumstances. So, but we're here and we're excited to hear everybody's presentations today. Let me go through a few logistics, the structure of the morning and the afternoon. Students basically have 10 minutes to present and 5 minutes for question and answer. Just a reminder, as you probably already noticed, this will be recorded and is being recorded. Presenters, keep an ear out for Noura, who will gently give you a call out at 5 minutes, at 2 minutes, and at 0 minutes. And if you notice you're running out of time, adjust accordingly to stay within that 10-minute kind of frame. Audience, please do submit your questions in the chat box. We welcome question and answer time period. That's during that last 5 minutes. And if you can put them in the chat, great. Noura will be calling out the questions. Of course, at the start, if there's a pause, I'll try my best to throw out a question to begin with, get everybody warmed up, but we're happy to read out. Noura will be reading out the questions that are in the chat. If we run out of time for Q&A, the presenters will answer publicly in the chat if there are remaining any questions. So let's see what else. We do want to encourage all of you to ask questions. There will be, I believe, 20 presentations today. There's going to be a break at 10:20 to about 10:35. We had a last minute cancellation. And then there'll be a 5-minute break at 11:50. And then our 30-minute lunch break at 1:25. Just a reminder, I have to step out for a noon meeting, but eagerly will be returning for the afternoon sessions. So thank you all. And with that, I will turn the mic over to Fatima Al-Shamari, who will be our first presenter.
Thank you for that introduction. Hello, everyone. My name is Fatima Al-Shamari, and I'm going to be presenting on workplace violence against junior doctors in Iraq. Can everyone see my screen? Yes, okay, great. We're going to start off with a brief background. We're going to go over methods, results, conclusions, and recommendations, and then acknowledgement. Sorry, I'm having technical difficulties. Okay. Great. So every interpersonal relationship is shaped by trust, but the patient-physician relationship is especially critical because it serves as a precedent for preserving health. Unfortunately, this is not the case between patients and their doctors in many places in the world, where doctors have reported violent assaults, threats, and aggression from patients and patient relatives. As a result of these cases of violence, health systems become considerably more vulnerable and incapable of meeting public health goals. Now, this is not a problem that's exclusive to just one community or even one country. Studies have emerged from every continent, revealing parallels in violence against doctors and healthcare workers. Some examples are listed here. For our study, we focus specifically on one country, Iraq. And that is because in addition to experiencing violence from patients, the doctors have to also navigate a fragmented healthcare system. After decades of civil wars and international invasions, Iraq's healthcare systems are in disarray. An extensive history of suicide bombings has caused building infrastructures to remain damaged. And today the country faces severe shortages in critical medical supplies, including oxygen tanks, medications, and vital medical equipment. There are not enough hospital beds and hospital rooms to accommodate the demand of the public, and there's a serious lack of doctors in the country. Specifically, the World Health Organization reported that there's a ratio of only 7.8 doctors per 10,000 people. So we wanted to better understand how violence against junior doctors influences worker retention and job satisfaction. Our study was also conducted in part to inform new conflict mitigation training in medical school curriculums in Iraq. And the reasoning is that if medical schools can embed conflict mitigation training, then doctors would have the skills to de-escalate situations that may result in violence. Here's an overview of our project timeline. Data for this study was collected last December and January from hospitals sampled from Baghdad and Karbala, two major cities located in central Iraq. An interview guide was piloted with 3 junior doctors at one hospital in Baghdad, which informed further edits for clarity. And both guides were made available to the interviewees during conversations conducted either in English or Arabic, depending on the physician's preferences. To recruit subjects, we made it known that we were going to be on site by visiting breakout rooms, or break rooms, and recruited available junior doctors by explaining the purpose of the study. The interviews themselves were conducted in hospital conference rooms for privacy, and we asked junior doctors to introduce us to their colleagues for interviewing. Interviews were transcribed in real time using MacBook Diction software, and then transcripts were promptly shared with the rest of the study team via email. Our co-investigators read through the transcripts, shared their queries, and helped shape future interviews for additional prompts as the themes emerged. The study design and reporting of the data were based on CORIC guidelines. 2 researchers then read through the transcript, developed and compared codes to ensure rigor. Codes were developed using Atlas TI version 9 software, and independently coded interviews were then merged with discrepancies addressed by a 3rd reviewer. Sorry, it froze. Okay, we're going to discuss our findings. Okay, there we go. From the 22 interviews that we analyzed, a total of 6 themes emerged in the process of thematic analysis, with 3 at the societal and structural level, 2 at the hospital level, and 1 at the individual physician level. And we're going to go in depth through those. So the first theme at the structural level is that the structure of the medical care system creates a sense of scarcity, which generates high emotions as people compete for attention, supplies, or space, which are often difficult to find or afford. And this theme acknowledges that the healthcare system often undermines doctors' abilities to give adequate care to their patients. Because the country faces a severe shortage of doctors and lacks sufficient funding to equip hospitals, patients and their families will project their frustrations in forms of violence against doctors. For example, one doctor summarized the gap between the hospital's low capacity to treat patients and the high demand for treatment. They said, "We don't always have enough rooms, equipment, or doctors. It's not our fault if we're not functioning to meet society's needs." The second theme at the structural level is that the public doesn't understand the concept of triage well, which explains the anger at delays in receiving healthcare services. This theme illustrates how patients' perceptions of the healthcare system can create frustrations. And that's particularly true when patients and families present expectations for care that are inconsistent with the concept of triaging patients with the highest needs first. And one doctor, for example, recalled 2 days ago is in the ER, and we had a patient here that was here due to psychological stress, and her mother was not convinced by the lack of gravity in her daughter's condition. And she was shouting and calling doctors names. I was on the receiving end of her insults. This quote illustrates how the doctor was abused when a patient's mother disagreed with how the doctor triaged the case in the emergency room. The patient's condition was not as bad as the mother had perceived it to be, and her disagreement caused her to lash out against the doctor. Our third theme states that the structure of the medical education pipeline generates doctors who are quite young, may not be fully prepared for these challenging roles, and lack the skills and authority to respond in the moment of family attacks. In many of the interviews, junior doctors shared the experiences that demonstrated their lack of confidence in their work. And when a doctor is not confident, patients and patient relatives may doubt the doctor's capability in diagnosing and treating. This sense of doubt, coupled with the patient's relatives' protective instincts, has targeted doctors for abuse. And one doctor, for example, stated that many things can cause the violence. One example is the whole structure of the hospital. We need more hospital rooms, more doctors. One doctor cannot be responsible for the whole floor because we might make mistakes if there's too much work for us. Moving from the structural to the hospital level, theme 4 states that patient families perform violent or hostile acts towards physicians who may not meet their expectations to exercise instinctive protection or devotion to the patient. For example, one doctor stated that families are very protective of their patients, and that protectiveness can sometimes turn into fear and anxiety. Without health literacy, nothing you say to these patients will calm them down or de-escalate the tension that they're already feeling. Even if you explain to patients a diagnosis or a treatment they need, they will always insist they know better. This doctor describes the patient's fear and mistrust of the healthcare system and how it can manifest as violence. And the next hospital level theme that emerged states that doctors reported they believe family attacks persist because patient families are not facing legal consequences. So many of the doctors we spoke to attributed the high rates of attacks to the lack of legal consequences for the perpetrators. For example, the system is welcoming this behavior. If the law was stricter, then the patients would not dare to hit any doctor. The doctors are not always the victims because sometimes they do make mistakes, but it should not be resolved by hitting. There should be a strong law and a strong court to deal with it. And this illustrates how doctors believed that violence could possibly be reduced if perpetrators face consequences for their actions. The last theme now moves to the individual level and says that doctors who are targets of verbal and physical violence experience mental health problems, including depression and loss of self-esteem, and contemplate leaving their positions. So one of the consequences of violence is that doctors will consider leaving the country to practice elsewhere. Or face mental health problems. For example, one doctor stated that my mental health is not very good. When I first started being a doctor, it was hard, I was frustrated, I was angry, and I was scared. And sometimes I called in sick to not come because I would wake up feeling very miserable because I didn't want to go back to the hospital in some days. In conclusion, decades of war have diminished infrastructure and undermined doctors' ability to provide adequate medical treatment to their patients. Junior doctors in Iraq continue to experience high rates of physical and verbal violence daily and are seeking ways to leave the country. Addressing these complex problems requires the involvement of multiple stakeholders and robust monitoring, and strengthening the country's health systems by addressing patient concerns and providing better staffed hospitals can reduce the violence significantly. And finally, for recommendations, there are no simple solutions to ending workplace violence. However, concentrated efforts by the Ministry of Health can reduce this violence significantly. At the individual level, training young doctors to recognize situations that could potentially escalate to violence and implementing interpersonal skills to mitigate those instances. Addressing organizational issues like care quality and processes through strengthening medical infrastructure could also significantly help. And at the structural level, it's necessary that the public understands the concept of triage, because the Ministry of Health should inform the what am I saying? The Ministry of Health could take steps to inform the public about the concept of triage through educational channels and media. And finally, I'd like to acknowledge that this work wouldn't have been achieved without the help of Dr. Ali Musawi for reviewing the questionnaires and obtaining approval from hospital administrators, and Dr. Kirsten Bima Sophie for contributions to coding the transcripts. And a special thank you goes out to all the junior doctors that participated in the interviews. And thank you to all of you for making the time to attend my presentation.
Thank you, Fatima. Great job. I'll just pause a second to see if there are any questions. I could throw one out too. Okay, Amy, I see your hands up. Go ahead.
Yes, I would just like to acknowledge the presence of Dr. Riyad Lafta from Baghdad Mustansiriya University in the room, who is on our clinical faculty and so generously supervised Fatima on this project. And I wonder if between Fatima and Riyad, you might tell us a little more about the upcoming training or the trainings that are being planned for junior doctors to help mitigate this problem.
Fatima or Dr. Lafta?
Yes, thank you.
We cannot hear you.
Hi, everyone. Thank you, Fatima, for this.
Oh no, I think the connection was
Yes.
bumpy.
Maybe Fatima,
Can you hear me now?
fill in.
Can you hear me now?
Yes. Go
Can you
ahead.
hear me now, Amy?
Yes,
I
go
hear you.
ahead.
Thank you very much. Hi, everyone. Thank you very much. And thank you, Fatima, for this nice presentation. In fact, we are planning for a training course for those junior doctors, just in a trial to de-escalate violence by like improving their skills, communication skills, especially, and how to deal with violence, how to absorb it, because although we know that they are not because of violence, they are the victims. However, what we can do is to train those doctors on more and better communication skills, because they are deficient in experience, or most of them are newly graduated. But I think the main target should be the population, maybe through the media or other education campaign to increase their awareness about the importance of the role of health workers in affording health services to them, and that violence will not only affect the health workers, but will negatively reflect on the healthcare services that are afforded to the population. Thank you very much.
Thank you. Fatima, do you also have a response, or should we go to the next question?
Thank you, Dr. Riyad, for that. I guess in response also to, or I guess to add to it, my study is the first to explore violence against junior doctors using qualitative methods. So many studies have been done before using quantitative methods such as surveys, questionnaires, but my study explores sort of in depth and more. It was first designed to explore what the doctors were feeling and as far as wanting to leave the country, but it can also contribute to the understanding that we have about conflict mitigation training. It was pretty evident in the way that these doctors responded that some of them had no idea how to respond in the instance of an attack. They would either reciprocate the violence that they were experiencing, or they would completely shut down. And so we do feel like these results can justify the need for conflict mitigation training. Yeah.
Okay. I think Nora is going to read off one more question and then we're going to be out of time. So, and if you could answer the remaining in the chat, that'd be great, Fatima.
Yes, so this question comes from Claire, who says, amazing presentation. Of the 22 doctors you spoke with, how many of them expressed what they were wanting, that they were wanting to leave the country, or had they looked into it? Did you notice any trends or correlations?
Sure, that's a beautiful question, Claire. Thank you so much. I actually have a slide on this that I didn't share before, but here's a representation. So we spoke to 22 doctors that we included, and of the ones that were trying to actively leave the country, actually 59% were trying to leave. 86% had already researched the immigration process. And as far as correlation goes, so we noticed that the doctors with that had graduated more recently were more leaning towards actively trying to leave the country. There was no correlation between the number of experience and wanting to research the process. I think it was overall, it was spread out, but younger doctors were more leaning towards trying to leave the country. So thank you for that question.
Okay, I think we're out of time. So Fatima, you know, there are a few other questions in the chat. If you wouldn't mind responding in the chat, that would be great. And so we're going to break now again until 10:35.
Yes,
Okay.
10:35. A little bit before that, please come back. We're going to take a little pause. Thank you.
Thank you.
Thank you.
Okay. All right, we're going to go ahead and get started.
Yeah, I think Sammy needs to press got it on your screen.
Oh, okay.
Yeah.
All right.
Yeah, so thank you everybody for returning to our MPH Thesis presentations for global health. The next presenter is Sammi Birmingham Abouta. So we're very, very excited to hear your presentation. So take it away.
All right. Hi, everybody. My name is Sammi, and I am presenting my thesis on our title, Talking Story About Quitting Pugwa, an exploratory study on self-driven cessation of betel nut chewing on Saipan. On my committee, I have James Pfeiffer and Holly Barker. I'm going to skip positionality because 10 minutes is not a lot of time to present. So just to orient ourselves from where I'm from and where we are. So over here, we're here in the West Coast, and it's about a full day of traveling to get to where I'm from in Saipan in the Sinai. Saipan is the most populated island of the Sinai and where my research is based. Zooming into Micronesia, so Sinai is part of Micronesia, which encompasses a bunch of other smaller islands where pugwa or betel nut chewing is a cultural practice, as well as throughout Oceania, which includes Melanesia and Polynesia. So what is pugwa? Pugwa is the Chamorro word for areca nut or betel nut, and how I will be referring to it throughout the presentation. It's the fruit of a palm tree that's chewed as a psychostimulant, similar to drinking coffee or smoking a cigarette. It's usually mixed with tobacco in the form of cigarette, slack lime, which is the white powder thing, and pupulu, which is a leaf that you put into the mix. And it's considered a cultural practice in the Sinai, as well as a lot of Pacific islands. It's also chewed by 600 million people in the world. So it's also popular in like South and East Asia. So pugwa is considered a group 1 carcinogen, and it's linked, chewing with or without tobacco can lead to oral cancer, it's gum disease, it's addictive, and a bunch of other unhealthy traits. In the Sinai, 43% of adults chew pugwa, and 88% of people add tobacco into their mix. Tobacco-related oral cavity and pharynx cancer is number 2 in the Sinai, though I think pending the 2020-2021 data, it's going to be number 1. 42% of people that are diagnosed with this cancer pass away within 5 years of diagnosis. And I think that's something that we really see in our community. And so because of that, 2 in 3 chewers do want to quit. So My research question is, what are the experiences of individuals in Saipan that have quit chewing pugwa? And my aims are to understand the facilitators and barriers to self-driven cessation of pugwa chewing, and from those lived experiences, identify culturally centered and community-driven solutions for improved cessation. So my research was qualitative. My sample size was 22 individuals that were recruited through snowball sampling via social media and word of mouth, or how I like to say coconut wireless back in the islands. The data collection was semi-structured interviews that were in person, over Zoom or over the phone. And then I coded inductively and did a thematic analysis to pull out the following themes. So these were the 4 themes. The first is the social environment is an agent for the start and end of pugwa chewing. And I say social environment as a broad term because it includes peer pressure, a sense of wanting to belong, but it also includes just the accessibility of pugwa. It grows on the trees, the visibility, just seeing somebody chew, even if they don't offer it to you, makes you want to chew. And it's something that people do to feel not awkward in social settings. So it's really a broad thing that is the start and barrier to the end of pugwa chewing. Second is that individuals prefer peer services over public health offerings. Most of my participants said they would not use public health offerings because of feelings of pride, feelings of mistrust in the healthcare system, and also just truly believing that there could be no service that could instill the willpower to get them to quit if they didn't have it already. And that's very similar to tobacco cessation. The third is that there's a desire for localized information on pugwa and oral cancer, which I'll talk more about later. And then lastly, which was the most surprising for me, was that pugwa chewing may have less cultural ties today. And so going into my research, my assumption was that culture would be a huge barrier to cessation. And that's what we see in the literature that's coming out of the University of Guam, because they're doing the most research on betel nut in Micronesia right now. But within Saipan, this may not be the case. All right, so my recommendations. First is to reframe social support in a cultural context to boost individual cessation efforts. So culturally, pugwa equals togetherness, and it's customary to share pugwa. So when people quit, others struggle with not offering pugwa and consequently pressuring them to chew. So in this quote, this person said, when I quit, I noticed that my family supported me. They didn't encourage me to keep chewing by handing me the bag and say, here, don't you miss it? They didn't put it in my face. And I was so very thankful for that. And so I believe that we need to increase community conversation, maybe through awareness campaigns, to reframe our relationship with pugwa and teach us that we're not being disrespectful for not offering, that can be a way that we can look at it as being respectful. Second is that public health efforts should be aimed at supporting peer-driven services. Once people had the willpower and were ready to quit, they wanted peer support. They envisioned this as like meetings where people who have successfully quit came in and shared their experience, or a buddy system where they could check in with somebody who was also working on quitting to help them stay on track, and really just wanted somebody that shared experiences with them to help them through this journey. Third is that we need to increase education on pugwa, its linkage to oral cancer, and as well as cessation experience. Many participants wanted to know what caused oral cancer in relation to chewing, and a lot of stuff is still unknown back home.